Deputy President. I was asked to unpack the emergency response plan for the health unit, which is at the hospital level, so I'm going to try and explain it in that aspect. What is the emergency response plan? It's just a framework of timely and effective deployment of staff and resources to respond to emergencies. Each hospital should have a team that works around those resource allocation times when emergencies come. And it's just standing instructions for how each hospital handles its emergency situations. I'll give you the basic emergency phases. I borrowed this from the bigger disaster approach. So there's mitigation. That's the biggest challenge. Mitigation and preparedness is what we have to always try to get to. And then there's a response when your emergency eventually happens. And then there's the recovery time. So all these are phases you go through an emergency. That the most important parts are the mitigation and preparedness for every staff of the hospital, disaster management plan, mass casualty incident. You have to have a clear structure of how to handle those phases. I'll run through a few definitions, what like Joseph had stated earlier. What is a disaster? We may mix up some of these things, we may not understand the detail, but a disaster, as WHO classifies, this is an ecological phenomenon of significant magnitude to require external assistance. And the American College of Emergency Physicians states that disasters occur when the destructive effects of a natural man-made forces overwhelm the ability of a given area or community to meet the demands of the healthcare. And what is the mass casualty incidence? It's what we normally call disasters in Uganda. It's that incident that produce more casualties than a customary response can handle. So we've had mass casualty instances here in Kampala, the 2010 bombings and the fuel tanker that exploded on the bypass 3 years later. And you need extraordinary arrangements of resources to manage this. Why am I dwelling on this? Because in 1981, WHO realized that the importance of relief in emergencies is there, but preventive measures and preparedness are as important and fundamental in management of emergencies. So as much as we are thinking of a knee-jerk reaction to the emergencies, we have to have had a plan prior to what will happen when we get into the emergencies. I just highlight the guiding principles. So for each emergency that comes, there should be clear lines of responsibility allocated for people, from the junior staff to who he reports to at the hospital, to which team does what, and it should also have an all-hazard applicability. So the hospital should ideally have sat down and thought and said, fine, what are we at risk of getting in this place? If you're in Buruda, you think about landslides. If you're in Jinja, you think about the trauma. If you, depending where you are, think about that and have applicability to that. Scalability should also come in place where you have to scale up resources, human resource, time, and specialists to respond to your emergencies when time is needed. And these should all be at a particular place or with a particular committee. I'm going to show you the structure later on. And during emergencies, it should be the whole curve of health. You don't forget about other services, maternal, child health, mental health in the emergency, and you focus on the emergency. It should be all-encompassing. Now, the knowledge based on previous experience is what I would say. All emergencies happen. What have we learned from the 2010 bombing? What have we learned from the landslides? What are we using to apply that to prevent further emergencies? The biggest key aspect is multi-sectoral complex partnerships. It's expensive to run emergencies. You need help from whichever partners you can get. I mentioned some partners ahead, but as a hospital, I'll talk from the level point of view. You have different contact people in the Ministry of Health and the Prime Minister's Office in case of emergencies when they happen, and in cases overwhelming of your medical services. And like the framework has said, there is no national policy in terms. There is in terms of response, but to direct people to say this is the team that responds to emergencies, and they should be given accordance in terms of the legalities. I thought I'd put in just a small picture of how the mass casualty incidents at a hospital should ideally be responded to. So you have levels of authority and response from incidents at local emergency control center, which should be at your hospital health unit, and this should be escalated to provincial state emergency control center. It can be district or regional. Then there's national emergency control center that takes up the communication about any emergencies and breakthroughs that are in the system. Then there's a ministerial cabinet approach. That's where the Prime Minister's office sits in our structure. So, in your planning at a unit, you should have an incident commander. Usually supposed to be the most experienced person or the most senior person who happens, for Mulago's case, to be usually the head of the accident and emergency. And these people should ideally meet once or twice a year to have reviews for the emergencies and the different committees that are there. There's operations, there's planning, there's finance and logistics. All these meet to plan for emergencies, because when the emergencies come, all these guys are activated and the incident commander is the one directing how flow happens. So what are the components? I'm going to now bring it down from the national level to the unit level. What are the components for an emergency program? So each hospital ideally should have an emergency operations plan, where it outlines the hospital's plan to respond to emergencies. And it may be single or multiple hazard, because you can think about different scenarios. If you're on a highway, it can be multiple hazard trauma, it can be any other thing, landslides and everything. So you should have an incident command system, and this system should come in play when the hazard or incident happens. And the team I showed you is what it comprises of. Ensures that operations should be covered, finance, planning and logistics. Those are the four of the most important tenets in management of a disaster or preparation committee at hospital level. And there's an incident command center. Usually in the accident and emergency, should be space where people are communicating about what has happened at the accident site, who is responding and how they're going to move their resources to the site. Hazard vulnerability analysis should have happened prior and evaluates the threats that the hospital is likely to face and plan for them. Key contacts, I say it again, it's not a standalone team. Emergencies need key contacts in government, police, fire, all these departments. It's a big framework of teams that respond to emergencies and mass casualty incidences. Then the last one is the exercises and drills. We don't do those because we focus on primary health care and delivery of health care, but ideally each hospital should have a drill. I think Mulanga has done them with CAA. I think I've done 2 with the airport, but not at the site. But we go and have the drills done. This should be part and parcel of an annual plan for your health unit. So what are the components for an emergency response at the health unit? So it's a 4-pronged approach. You have to have the initial triage, where you get the communication, say the bomb blast has happened, and have a team that's going to go out for patient extraction. Second triage is done, and medical treatment, then transportation of the patients to the service, primary health service point. So the interventions during the initial triage, they are to be performed by the basics. The initial triage is receiving people according to resources, and you make quick decisions with the patients. So you do the open airway and stop and control breathing, and that's initial triage, and you classify them. And how do you classify these patients? There's a triage procedure for adults, where you have the green, yellow, red, and black. This can be done by the first team that goes out, and green is minor injury, or the walking wounded. Yellow is delayed and can wait for treatment. Red is immediate and urgent patients that need treatment. Black are the ones that are dismayed and classified as dead. For the pediatric, there is a jumpstart pediatric patients in mass casualty incidents. This is primarily to optimize triage of children in mass casualty incidents, and you have a resource limitation, so you're trying to enhance effectiveness of your resources. So you reduce emotional burden on personnel that goes and is assigned to have initial treatment. So your most senior team or colleagues are the ones that will go out and make these decisions, especially if there are children involved in the mass casualty incident. The algorithm of the jumpstart pediatric and mass casualty trial is simple. You find out if the patient is able to walk, classify them green and minor, and have secondary trials done to them. If the patient is breathing, if you're not breathing, then you can position the airway and get, if it gets breath again, then you get classify him as red. If position of air doesn't help and is apneic, you give some rescue breaths. If the rescue breaths are not of any effect, you then classify the patient as deceased. So these are quick decisions that have to be made because there are a number of patients that need attention. And this, I think I'll end here for now. And just say that mass casualty incidents are not uncommon in our setting, so preparation is key. And preparedness and management is very essential for every health unit. I know the burden of resources is enormous, that you focus only on healthcare and treatment and emergencies. Triage is very important. I think in 2010, when in the ICU with Arthur, we had issues of over 30 people needing ICU beds and we only had 8 beds to give. And some people had to support the floor, so you make it who is going to take up that ICU space and ventilator, and who is going to be left for make a quick decision, because you don't have the resources. Yeah? And save as many as you can. That time, I think we did 48 or 72 hour calls. The theater was running non-stop. But it's a very big resource draining and sucking experience that you have to prepare for it as much as possible. And lastly, not forgetting your safety and safety of other team members in the process, especially if you're going out to extract these patients from dangerous places and chemical areas like the syringes and everything. Thank you very much.